Hi, I'm Gabriella McCarty. I'm a nurse practitioner at North Shore Gastroenterology in Cleveland, Ohio area. And thank you so much for joining us for the GAP MASLD and MASH Community Network, where we're going to explore the latest in liver health and GI care. I have been at this private practice for the past 26 years. I do general GI, IBD, and hepatology. And I come across a lot of fatty liver disease patients. And I'm going to say that I come across it because 75% of the patients that I see that have fatty liver are not coming in to see me for fatty liver. They are coming in to see me for GERD or even colon screening. But I notice that they have metabolic syndrome, or I'm perhaps digging through old imaging. So 15, 20 years ago, I find an ultrasound that says fatty liver. Now, mind you, it just says it in the body of the report. They didn't even always put fatty liver into the actual impression. So when I bring that up to patients, 50% of them say they had no idea that they had fatty liver. Nobody ever told them. The other 50% will tell me that, my primary care told me I had fatty liver 20 years ago, but they said lose weight, it's no problem, nothing to worry about. But this has become a problem that is increasing. We know that fatty liver in itself can eventually lead to cirrhosis, even if you don't drink alcohol. So we'll talk about a little bit about MASLD. So this is metabolic dysfunction associated liver disease. So this nomenclature was changed back in June of 2023. There was a multinational consensus panel that was done, and it was changed from NAFLD. So MASLD was NAFLD, and MASH used to be MASH. So a little bit different, but I still say fatty liver with my patients because I feel like it is the easiest to understand and comprehend. So we know that patients that have increased fat in the liver, so MASLD, if they have any one of 5 cardiometabolic criteria, that this can be diagnosed. And that is anywhere from a BMI of greater than 25, a waist circumference greater than 94 in males, greater than 80 in females, fasting glucose greater than 110, hemoglobin A1C greater than 5.7, or they are type 2 diabetic, a blood pressure greater than 130 over 80, or they are on antihypertensives, triglycerides greater than 150, HDL less than 40 in males, less than 50 in females, or they're on lipid-lowering agents. Now, I don't know about your patient population, but in the Cleveland area, a lot of the patients that I see meet this metabolic criteria. So to assess severity, especially fibrosis, liver biopsy is not necessary anymore for this. So we often use non-invasive tests. So this is FibroScan, which is VCTE, vibration controlled transient elastography. So this is basically an ultrasound technique that measures liver stiffness. So it gives us a couple scores, how much fat you have in your liver, and if you have any scarring in the liver. So it gives us a little bit better baseline, and patients do like to know that. If anything, it gives you a kick in the butt if you have some fibrosis to do something about it. So we also look at some baseline LAM scores, like something called the FIB-4. So that basically is a calculation that takes the patient's age, their AST, ALT, and their platelet levels. Now, if you have Epic as your EMR system, you can just simply put .fib4 and it'll bring up the answer. You can simply put it in your phone or your computer as well. So if there is a FIB-4 score of 1.3 or greater, these patients can be a little bit more at risk for fibrosis. ELF testing, ELF, enhanced liver fibrosis. This is actually a blood test that can be done. That's a good prognostic lab for progressive liver disease or progressive fibrosis. Well, the problem is this doesn't always mesh. We don't always get sometimes the right results. We might get a FibroScan that has a high IQR. So maybe the probe hit over a vessel. Sometimes we get discordant readings if there is cholestasis or liver congestion. and things like that. So sometimes I'll see patients that have a CT scan that's showing cirrhosis, but now the fibro scan is F0. The platelets might be somewhere in between on the lower end, but they don't have thrombocytopenia. So these are the patients that we want to perhaps do a liver biopsy on. I will also order MR elastography. That's helpful in like morbidly obese patients where it's really hard to get a fibro scan reading. Although this test is expensive and a little bit harder to obtain, it takes a long time to get in for that test. And in our area, patients have to go downtown to get it done, which is always a hassle. So every tool has its own, cutoff values, sensitivity, specificity. So it's important to get the most information that you can on each patient. And if they have elevated liver enzymes persistently, you still might want to get that liver biopsy to rule out any other causes, autoimmune hepatitis and things like that. So there's always a question of, who needs a biopsy, who can be followed conservatively. So I would definitely say if these tests disagree, that I would still proceed with a biopsy. And I would repeat testing. Even if you're unsure, I would make sure patients do get another fibro scan in maybe 6 months or a year even, especially those with greater than 2 metabolic risk factors. We know, the liver is very good at regenerating itself if you take care of it. So it can progress or regress. And there are many different factors that contribute in patients, genetics, the metabolic factors, and gut microbiome all plays a part in liver health. So lifestyle matters. I still say the same to all of my fatty liver patients. I tell them to follow up with their primary care for good blood pressure, cholesterol, blood sugar control. I tell them to exercise 4 or 5 days a week. Get your heart rate up for 45 minutes, not just to walk around the block. I encourage Mediterranean diet since that has been a diet that has been pretty well studied in fatty liver. I will give them information on that in the office. As far as weight loss, I say a good goal to look at is losing 10% of your total body weight over a 6-month time period. So 10% of your total body weight, not a huge amount, but even that amount can help the liver. The liver is very good at regenerating itself. Avoid alcohol. If you drink alcohol, that can make that progression faster. And remember, even if you don't have any symptoms, or even if your enzymes are not elevated, that fatty liver can eventually progress to cirrhosis. And you never know who those patients are that have maybe those worse genetics where that progression can go faster. So that basically wraps up what I do in my MASLD patients and kind of what I look at and what further testing might be needed if you do have those patients where you're just not sure. And just make sure that you're getting the most information on every patient. On everybody that gets a fibro scan, I'm documenting a FIB4 score. I'm documenting their metabolic factors. And I think this problem is becoming more and more global and just progressing. Now they have, pediatrics that are developing fatty liver cirrhosis, unfortunately. So it's so important to think about this, even when you're not seeing a patient for fatty liver or for elevated liver enzymes. It's important to bring it up if you see something. And I hope that helps. Thank you.